Vision, can we proceed now?
Yeah, we are going live now, everybody.
Yes, yes.
Okay, so we are live now and we are starting out today's program. A very good afternoon and a warm welcome to one and all present here in this session. I am Debulina from Planet. We are very much proud to be a part of this webinar as a digital partner. As you all know, Planet is India's largest live digital CME and doctors-generated medical content platform. So now with all of you, I'm going to share a short glimpse of Planet. Thank you so much, all the doctors, for your patience. You all are invited to visit our website, which is www.clarnet.com. So now, without further delay, I would like to hand over the session to Dr. Prashant Karyasa to start with our today's scientific program. Over to you, sir.
Thank you so much. And today is our 24th Neonatal Pathshala. And on behalf of NNF Gujarat, I, Dr. Prashant Karyasa, Secretary, one and all, and I request our President, Dr. Sandeep Trivedi, to welcome the guests. Sandeep, bhai, unmute.
Thank you, Prashant. I am welcome today's expert, Dr. Vivek Arora sir from Udaipur and Dr. Nehal Ben from Ahmedabad. And also welcome Dr. Sanjay Chavda, who is the presenter. And very useful pediatrician and neonate. And I also all the participants who joined through the YouTubes and other links. Thank you, Prashant.
Yeah. So thank you, Sandeep bhai. We are also having with us Dr. Yogesh Parikh, the project in charge, and Dr. Mohit Sane with us. Now coming to the point directly, today Dr. Sanjay Chavda, who is a fellow in Neonatology at Nirmal Children Hospital, Surat, is going to present a case. And we do have two experts with us today. First expert, we do have Dr. Vivek Arora sir. Sir is a senior professor in pediatrics and head HOD of the Department of Pediatrics, R&T Medical College, Udaipur. And sir is mainly working in neonatology. He has also done a senior residency in neonatology from KEM, Mumbai. So we welcome Dr. Vivek Arora sir.
Thank you. Thank you very much, Doctor.
Yeah. Along with sir, we do have Dr. Nehal Patel with us. She is professor and head Department of Pediatrics, GMERS Medical College, Sola, Ahmedabad. And she is currently the president of Women's Wing AOP Gujarat. She is a EB member of AOP Gujarat, and she is a trainer in BNCRP, Advanced NRP, FBNC, HBS, and NBSU. And she also received a Young Researcher Award in 2014 by IAP Research in Child Health Group. So we welcome Nehal ma'am also.
Thank you all. Thank you, Prashant.
So without taking much of a time, I request Sanjay to start case presentation. During the presentation of a case, both the experts, Dr. Vivek sir and Dr. Nehal ma'am, can ask the questions on any slides. So Sanjay, to start the case presentation. This is a real case which happened, and he is just presenting a PPT presentation of a real case. Dr. Sanjay Chavda, please. Mohit bhai. Yeah, your screen is full visible. Sanjay, you can start. Sanjay, you need to unmute.
Hello, sir.
Yeah,
I'm audible.
Audible.
Thank you so much for Neonatal Pathshala giving me great opportunity to present this case. I am presenting the case of a baby of XYZ twin first with born to 26-year-old primigravida mother with a twin gestation. Emergency section was planned in view of pregnancy-induced hypertension. Antenatal Doppler suggestive of high resistance flow in umbilical artery of the both fetus, severe polyhydramnios in a fetus B. The birth weight of this baby is 870 grams and gestational age was the 26 plus 6 weeks. Antenatal history. IVF was done in view of primary infertility. Mother has a history of a left side oophorectomy 5 years back in view of ovarian torsion by the laparoscopy. And the history is no history of gestational diabetes mellitus, no history of hypothyroidism. HB of mother is 11.5, HbS-AG, HIV, VDRL was non-reactive. TSS screening was done, which is normal. SB electrophoresis was done, which is normal. 2 doses of tetanus were taken. And antenatal screening. Antenatal USG is 12 weeks of gestation, which is dichorionic diamnonic twins. Nuchal translucency in fetus B was 4 mm. For that, NIPT, non-invasive prenatal testing for fetal free DNA in mother's blood was done, which is no aneuploidy was detected in this test. At the 20 weeks of gestation, antenatal screening was a single umbilical artery in the fetus A, polyhydramnions in fetus B. At the age of 26.5 weeks, which is the day before delivery, in the screening, mild oligohydramnions in fetus A, severe polyhydramnions in fetus B, and high resistance flow in umbilical artery in both fetuses. Antenatal drug history for mother is regularly taking routine drugs like folic acid, calcium, and iron. Tablet labetalol and nicardia was taken for a PIH a day before delivery. Injection betnazole, 2 doses, 12 mg intramuscular taken. First dose was before 16 hours of before delivery, and second dose was taken before 4 hours before delivery, which is partially covered in inadequate coverage for steroid coverage. Intrapartum
What do
history.
you think? Excuse me. What do you think? Dexona is better or betamethasone is better? What are the pros and cons of betamethasone and dexamethasone? What
I
do you
think sir,
What is the
both
guidelines?
drugs are equally recommended. But in India, betnazole salt, which is a mix of 2 salt, betamethasone phosphate and betamethasone acetate, which is not available in India. This is 1 salt betamethasone phosphate available in India. So in India, dexamethasone is preferred for this steroid coverage in antenatal pregnancy.
Betamethasone, which is available, is short acting, very short acting.
Short acting is available. Betamethasone acetate, which is not available, which is a mixture of 2 salt should be given, but it is not available in India, sir. So we should prefer dexamethasone, which is a 4 dose 6 milligram per kg, 6 hour parts for 48 hours should be given before 24 hour delivery, sir.
Okay, this is a twin pregnancy. Do you think double dose should be given or a single dose should be given?
So single dose should be given. It's
okay, it is correct. Correct.
Okay.
So it may be a twin or triplet. You have to give a single dose only.
Yes, sir.
Yeah.
Okay, Sanjay, can you relate your umbilical artery anomaly with the other diseases in the newborn?
Umbilical artery anomaly can be seen associated with renal anomalies, but should not be not recommended to do USG. If any anomaly should be postnatally corrected, postnatally seen, then we should recommend an antenatal USG, not routinely advised.
Anything you want to comment for flow? What you already have stated?
High resistance flow in umbilical artery was there, which is suspicious of but suspected of impending fetal distress, which may cause severe hypoxia in babies.
Can it go if the child is survived and it goes beyond? Can the high resistance flow in umbilical artery is predisposing factor to some disease in the newborn?
Yes, ma'am. High resistance can cause hypoxia, which may leads to IUG or SGA baby, and NEC necrotizing enterocolitis.
So it leads to the mucosal ischemia and one of the major predisposing factor for NEC. Okay, go ahead.
Okay. Intrapartum history, mother had a severe PIH. For that, emergency C-section was done. No history of leaking PV, bleeding PV, or premature labor pain for the premature delivery. There is a high resistance flow already I mentioned in umbilical artery of both fetus, severe polyhydramnios. Twins were delivered by C-section. Twin 1, which is vertex presentation, cry immediately after birth. No history of meconium stent liquor, mild oligohydramnions, single umbilical artery for twin first, male child, and 884 grams was there. In second twins, which is a vertex presentation, and cried immediately, no meconium stent liquor, severe polyhydramnions, male child, and birth weight was 870 grams. Baby had a poor respiratory drive, so we have intubated and shifted to NICU for further care. Postnatal history, baby was kept in a volume guarantee mode, 5 ml per kg. FiO2 was.
Sanjay, 1 minute. Okay. Poor respiratory drive, but the baby cried immediately or not?
Yes, ma'am. Baby was cried. A weak cry was there. Then baby had a poor respiratory drive, central cyanosis, and labor breathing. So we have intubated and then shifted to our NICU.
Okay.
I want to ask you one thing, that you were using a Began mask or you were using T-piece resuscitator?
Yes, sir. We have using some Began mask ventilation.
Okay. The other thing I want to ask, these are preterm babies. You should have given a CPAP trial in the labor room. If the baby is starting the resuscitation, and if the baby's Apgar score was what? Apgar score.
Apgar score was around at that time, sir. Weak cry was there. Baby's activity is poor, and central cyanosis was there. Spontaneous breathing is labored. So I think it would be for at 1 minute and 6 at 10 minutes, 5 minutes. Hello, sir.
Yeah. So you have intubated and taken to the nursery. Okay.
Yes, sir.
Okay.
So, sir, postnatal history, baby was kept on a volume guarantee mode, 5 ml per kg of FiO2 at 50%, PEEP was 6, and rate was 40 per minute. At that time, vitals was 148 per minute, SpO2 was 94, CRT was normal, brachial pulses were well felt, ABG was normal, and extra suggestive of a respiratory distress syndrome. I would cover general examination was that baby. It is anterior frontalis at the level. Umbilical cord was 2 artery and 1 vein. External genital male phenotype was there. Anal patency was checked, which is intake, and no other dysmorphic features was there. Systemic examination, respiratory distress was present, subcostal retraction was present. In cardiovascular system, there is a no murmur. Brachial and femoral pulse was well felt and equal on both sides. Abdomen was soft and no any mass was palpable. In CNS, there is in our nursery, there is a good tone and activity. The opening ABG on admission, there is a pH of 7.306. PCO2, which is metabolic acidotic side, PCO2, which is 39, which is normal side, PO2 131, which is slightly hyperoxic side, bicarb was 19, which is subnormal, and base deficit of -6.7, which is subnormal. This is an X-ray of opening X-ray. There is a bilateral ground glass appearance was there. There is a severe RDS. After that, we have managed the baby, was surfactant of 5 ml per kg neosurf was given. UVC and USC was secured. Investigation was sent, and first line antibiotic injection caffeine was started, and aminoven plus MBI was started. After giving surfactant, this is the
Sanjay, 1 minute.
Yes, ma'am.
For RDS, you said there is mild respiratory distress, severe respiratory distress syndrome. So how do you categorize the RDS in this child? By any criteria or just by visualization?
Yes, ma'am. I have a X-ray suggestive of ma'am a gross bilateral
MD?
ground glass
Okay. Any other
appearance.
clinical criteria have you gone for this child?
Yes, ma'am. We can use a Silverman-Anderson scoring for preterm babies, which was a subcostal, upper costal, and intercostal retraction plus.
That done?
Yes, ma'am. At the time of ma'am, after intubation, there was not a severe distress, but at the time of delivery, baby have a central cyanosis which is impeding to respiratory distress. But after intubation, we have shifted to our NICU. At that time, we have put into ventilator. For that time, ma'am, we have a PEEP of giving PEEP of 6. And volume guarantee mode. At that time, we have a Silverman Anderson score.
Okay, go ahead.
Okay. Then this is a post-surfactant X-ray. In this X-ray, we can seal the recruitment of lung, ET position, which is secure very well. IVC and UAC, which is secure in this X-ray. And at the 12 hour of life, we have done the investigation of PT and APTT report. In this APTT, INR was 1.5, APTT was derange 120. For that, we have planned for FFP. On day 2,
what do you think the cause of this PTTT prolonged, APTT prolongation? What do you think?
Yes,
what
sir,
are you giving FFP on the basis of APTT at 12 hours of age? He has increased APTT. What are you thinking?
This may be due to a immature.
Gone for specifically APTT. This the baby was bleeding from somewhere.
No.
Baby was bleeding from somewhere.
No, sir. We have a unit protocol. We have a extremely premature baby and extremely premature plus ELBW baby. We have a unit protocol for that 12 hour of life. We have to PT APTT. For that, we have a planned FFP. For reason for this deranged APTT was immature liver system. Immature liver was the reason.
Okay, but I
Any
don't
other
think
differential
so.
diagnosis you like to put for this prolonged APTT?
Prolonged APTT may be seen with in this baby early onset sepsis may be there. Torch infection, maternal torch infection, which is transfused to the baby, and
I think so. If there is no bleeding, it is not routinely to give FFP to the baby without bleeding episode or anything. Like we cannot give FFP.
Okay. On day 2 of life, there is a total feed infusion was increased to 120 ml per kg. Baby was NBM and volume guarantee mode of 3.5 ml per kg. FiO2 was 30%. PEEP was 6. HUS and USC was done, which is normal. 2D echo was done for PDA 1.8 mm left to right shunt with a PFO 2.4 mm left to right shunt with an impeding HS PDA at 16 hour of life. For that, we have started febrile injection.
I just want to ask one thing.
Yes, sir.
That a patient was intubated in the labor room, right?
Yes, sir.
So like, and you have given surfactant in the nursery. So you have given by Insure technique, okay, or Lisa technique, because you must have given by Insure technique. So you didn't have given any. The ABG was normal, so you didn't try to extubate that baby, because Insure is to extubate within 20 to 30 minutes.
No, sir. We have not Insure technique. We have put on the ventilator. And,
no, I agree. You have put on ventilator because of decreased respiratory muscle weakness, and you have given surfactant. The lungs are improved, alveoli are recruited, and nowadays we are stressing on non-invasive ventilation and extubation as soon as possible, isn't it?
Yes, yes, sir.
So like your consultant must have told you, to extubate this baby as soon as possible. So VAPS is prevented and sepsis is prevented. So like what you are thinking, you are after doing echo and USG, then you will extubate?
Yes, yes, sir. We have extubate after echo, and especially, sir, we have in extremely premature baby. We have not extubate.
The protocols are that after ventilation, you have to put this baby on CPAP, bubble CPAP. After giving surfactant, as soon as possible, you have to put under the cover of caffeine, injection caffeine. You have to put the baby on bubble CPAP. Okay, go ahead.
Okay, sir.
Yeah, one more thing. Which fluid you have used? The total fluid requirement you have mentioned, which fluid you have started in this child?
Yes, ma'am. We have started dextrose 10%.
I think it is wrong. D5
why
has to be.
Yes, why D10? Sanjay, why D10?
Yes.
Less than 1 kg, it is D5.
Because if you start D10 at the rate of 110 ml per kg, what will be the dextrose percentage or the GDR you will be delivering to the child?
Yes, ma'am. We are starting, ma'am, total parental ventilation or total parental nutrition, which was amino plus MVI.
So that haven't started on day 1. Have you started it on day 1?
Yes. We have started on admission since admission.
If you are going day 5, day 6, no, go back. Yes, go back. On day 1, have you started PPN?
Yes, ma'am. We have started amino plus MVI on day 1 with the first line antibiotic and injection caffeine. For that, mostly we have started D10 for a better GIF.
So which was the GDR you were giving on day 1?
GI because mostly we have started 4 to 6 mg per kg per day, and then we adjust according to RBS of the baby.
So you started with the 4 or 6?
4 mg per kg per minute.
Per minute.
Per hour.
Okay, go ahead.
This was okay. On 14 hours of life, there was a TFI of 140 ml per kg. NBM, from NBM, we have started 1 ml 4 hourly of feed. Baby was extubated to DOPF with a FiO2 of 50%. Pressure was 15/5 and rate was 20. I time was 0.7 second. Then when episode of apnea, for that we have increased the PEEP of 6 and FiO2 was increased.
So the apnea episode is after extubation, after how many hours the apnea episode?
Apnea episode was there after 2 hours of extubation. Then we have after 6 hours of extubation, baby had gone a prolonged apnea with a desaturation and bradycardia. There is a bag and mask ventilation was given, but failure of bag and mask ventilation. For that, we have to intubate this baby, and we have shifted to the ventilator with a volume guarantee mode for 5 ml per kg. Then we have stopped the feeding and we have gone for NBM. Then day 3, there is a restarted feeding of
1 minute, Sanjay. So the episode of apnea that you encountered and you managed the child. So what are the differential diagnoses you kept for this episode of apnea?
Differential for the diagnosis. First was the immature lungs.
Your lungs were recruited well in the next X-ray. And you already started with the
apnea of prematurity.
Apnea of prematurity.
Apnea of prematurity. And then possibility of sepsis, early possibility of sepsis.
Yes.
Then PDA, then IVH can PDA, then IVH, electrolyte imbalance, hypoglycemia, maybe
Can it be due to
hypoglycemia.
dysbiosis and NEC? Apnea can be a presentation of dysbiosis and NEC?
Apnea may be apnea, temperature instability, bradycardia desaturation, shock and perfusion may be present at NEC, NEC cases.
So which RT feeding you have started with?
We have started Neolacta 17 oblique ABM. If we prefer ABM, if not available, we have starting Neolacta 17.
So which is preferable?
ABM is the preferable for the baby for
right.
Preventing NEC.
Right. What in the EBM that protects to NEC?
Lactoferrin and IgA present in ABM, which can prevent NEC.
Okay. So what is the mechanism of action of lactoferrin?
Lactoferrin, it is a glycoprotein which is induce inflammatory reaction which cause stimulation of mucosa, regeneration of mucosa and proliferation of mucosa, the maturation of mucosa due to the lactoferrin.
Okay, so it stimulates anthrocyte production and the mucosal integrity. Okay, and decreases the pro-inflammatory cytokines. Both the way it will help.
Yes, yes.
Any role of probiotics?
Yes, yes, ma'am. Probiotic can help in the prevention of NEC in extremely premature babies.
So which probiotics are preferred? There are multiple probiotics available. So which probiotics in the neonate is taken into the trial and they have shown benefits?
No, ma'am, I had no idea, ma'am.
Okay. It is Bifidobacterium brevi that has been used in many of the meta-analysis. Okay. But
Yes,
still
yes.
the data are not supporting that much to be recommended. Okay.
Okay, okay.
Yeah, go ahead.
On day 3 of life, we have started again 1 ml of 1 ml feeding 4 hourly with ventilator support of 4 ml per kg. FiO2 was 30, PEEP was 6, and rate was 30.
Okay. Nowhere AG abdominal girth is mentioned. So it's not in the unit protocol to take abdominal girth.
No, ma'am. We have regularly monitored abdominal girth at 6 hourly at 12 a.m., 12 p.m., 6 a.m., 6 p.m.
So feeding was stopped. Again, it restarted, but the abdominal girth is not mentioned anywhere.
Okay, okay.
Okay.
Ma'am, HUS was done for that, which is right side grade 2 and left side grade 1 germinal matrix hemorrhage. CRP was 2 and sodium was 144. And day 4 of life, ma'am.
Do you measure NIBP in the nursery? NIBP in the nursery?
Yes, sir.
Okay, you have not mentioned this is the 4th vital parameter, NIBP, which is very important. So,
yes, so apnea, NIBP, abdominal girth, RT-SP rates when you are making the child NBM, then RT-SP rates, continuous must have been done. So these all are needs to be there in your presentation.
CRT,
yes.
CRT.
CRT, yes.
Yes, yes.
On the first day you planned for 4 FFP. Have you given it or not?
Yes, yes, ma'am. We have given 4 FFP, and then at the day of 4 of life, as a RT aspiration of 2 ml of brown aspirate for the we have done NBM of the baby. PT and APTT was done. There is a PT INR was 2.1 and APTT was 55. For that, we have given vitamin K therapeutic doses 1 one cryoprecipitate and one more FFP was given for that, and 2D echo was done for the baby which is no PDA, injection febrile which is held.
So
Then-
which are the drugs which will you are giving it for the PDA, but that can harm the child by NEC?
Yes, ma'am.
Which are those drugs?
Ma'am, antenatal, sorry, ma'am, steroid can harm the baby for NEC, and
Antenatal steroid can protect or harm?
protect postnatal steroid can harm.
Yes, postnatal
And
steroid harm.
postnatal
Then
steroid, and then indomethacin
yes,
was this the NEC, ma'am, and
and one more.
no,
Anything
ma'am,
about ibuprofen?
I don't know about ibuprofen.
Okay.
On day 5 of life, there is a RT aspirate of 1 m. RTF was started after clearing aspirators were there. 2 ml, 1 ml, 2 hourly was started. Again, there is a extubation failure. We have extubated, and within half an hour, we have to intubate the baby and shift it to ventilation for volume parenting mode. Short course steroid, which is dexamethasone, 0.5 mg per kg. PD, total 4 doses was given for the extubation failure. Then
1 minute, Sanjay. On day 5,
yes,
go previous slide. So day 4, you had an hemorrhagic aspirate. So what was the hemorrhagic aspirate in 24 hours? How you replaced it? What were the electrolytes? And why you decided to restart the RT feeding? What was the AG? Because here already, have you suspected by brownish aspirate? You must have suspected NEC. So what are the things you have taken care for NEC that you needs to tell by day 5?
on day 5, there is abdomen was soft. We have given cryo and FFP, and then we have started feeding. For that, ma'am, we have to.
Which were the antibiotics going on at that time?
Ma'am, first line antibiotic was going on.
Which
which
were
was,
they? Were they covering gram-negative bacteria?
Yes, ma'am. We have Ceftran and Levoflox. We are giving Ceftran and Levoflox was first line antibiotic, and
So by considering NEC, which antibiotics you should start?
we should considering NEC, we should start, ma'am. Add Metrogel should be added for NEC, ma'am.
It was added on day 4.
No, which was not added on day 4. We have added after that, ma'am.
Sanjay, Dr. Sanjay, I want to ask you that your antibiogram of your nursery shows such a high antibiotic as a first line. You should use antibiotic stewardship, and you should start. Your CRP was negative. You should have started with a lower antibiotic regime like pipzoamicacin or like that. But you have started such a high antibiotic Levoflox. I
Yes,
just
yeah.
want to ask that why you have started such a high antibiotic.
Yes, sir. We have
Fourth line antibiotic. You are using fourth line antibiotics. So the antibiotic stewardship is one of the best thing to avoid resistant bugs to develop.
Yes, sir. We have changed the antibiotic protocol according to antibiogram. Previously, we have first line antibiotics was Pipzo and Amica. Then, according to antibiogram, now our first line was Ceftran and Levo. Then Mero and Levo was the second line, and the third line was Meropenem and Polyb or Polystine.
Colistin, Meropen. Okay, but okay, your CRP
Previously,
is negative, and how can you give such a high antibiotic? Maybe because of ventilation you were giving.
Yes, sir.
Okay, go ahead.
On day 6 of life, there is a RTF increased to 2 ml 2 hourly, and on ventilator mode 4 ml per kg. FiO2 was 40, rate was 35. We have done HUS, which is a grade 2, and the right side and left side was grade 1 cerebral matrix hemorrhage. On day 7 of life, baby is tolerating feeding 2 ml 2 hourly, which is increased to 3 ml 2 hourly. On ventilator support 4 ml per kg, and FiO2 was 25 and PEEP was 5. At that time, we have done CBC, HB was 9.1, PCV 28, total count was 3200, and ANC count was 960, and platelet count was 3.18 lakh. For that, we have a new can added, antibiotic which was started for first line, which is upgraded to second line. Blood culture was sent, and 1 PCV planned for anemia. On day 8 of life, baby was extubated to a DOPAP, which is on setting of FiO2 of 50%, pressure on 14/6, rate was 20. On day 9, there is a baby has a brown aspirates. For that, we have go for a PT and ABTT. PT INR was 1.5, ABTT was 100. On CBC, 11.4, HB was 11.4, PCV was 35, total count 5,900, platelet 2.1 lakh. And from feeding to baby was NBM was done. Repeat 2D echo was done, which is normal. Vitamin K therapeutic dose was given, and X-ray abdomen was suggestive of this is portal venous cases in X-ray abdomen and liver shadow. This is a lateral X-ray, which is suggestive of in liver there is a portal venous cases. X-ray suggestive of lateral venous cases, and serial X-ray monitoring and USC abdomen was done. Steroid were held, and day 10 of life, baby was NBM day 2 on DOPAP. USC was done, which is air in linear hyperechogenicity noted in the liver and possibility of air in biliary radicals and portal radicals. PIC line was inserted at that time. ABG was done, which is 7.1 pH, 45 of PCO2, 62 of PO2, and 16.3 was bicarb, and base deficit was -12.
Okay, Sanjay. So up till now, the baby was never in shock, or you haven't given any inodrops up till now?
Yes, ma'am. We haven't given any drops.
Okay, so till now, what were the factors, predisposing factors in your child which has led to NEC? Can you summarize them?
Yeah, antenatally, history was inadequate coverage of steroid, prematurity, extremely low birth weight was there, and high resistance flow in umbilical artery in this fetus was there, and postnatally baby had a repeated extubation failure, and we have given extubation steroid short course for extubation failure. Then these are the reason for NEC. This risk factor. Sepsis, sepsis.
UVC?
Hi, UVC and USC causes the predisposing factor for the NEC.
Okay, and I cannot comment on dyselectrolytemia because that is not, and dysbiosis.
Yes, ma'am.
So there are many factors, okay, also dysbiosis. So
dysbiosis is the
stop feeding because you haven't given the BM. So there are so many factors which can predispose to NEC. For NEC, whenever there is brown aspirate, you have done the PT and APTT. Was there also, it also checked after giving the replacement of FFP and cryo, whether it is normalized or not?
Yes, ma'am. We have given. Sorry, ma'am.
How do you replace the RTE aspirates?
We have, ma'am, replaced the RTF with half DNS.
Okay.
Ma'am, after seeing there is a
Yes, I want to ask you, you have never mentioned the temperature of the baby any time. Temperature instability is the first sign for stage 1 for development of NEC. Temperature instability, tachycardia, bradycardia,
And apnea.
and apnea. So you have not mentioned temperature, so important in this baby. From getting into the nursery, you have to just monitor the temperature. And what you require in the labor room, that you should have covered the baby in plastic wrap without using clothes and bring to the nursery. So plastic wrap is nowadays recommended for less than 32 weeks of babies, 32 weeks of gestation of babies. So
Yes, sir. We
temperature
have used a
stability
plastic.
is very important.
Yes, sir. We have used a plastic wrap, and we have transported baby in a pre-warm mattress, baby mattress.
Okay. But temperature you have not mentioned. I don't know why.
Yes, sir. Yes, sir.
So important temperature. So important.
Temperature instability is
So Sanjay, many things we do, but when you are presenting the case, like in this platform or anywhere when you are giving exams, some things are important to mention also. So don't forget to take them in your case to mention it. Okay.
yes, ma'am. In day 10 of life, there is a NEC watch was done for we have planned a serial X-ray. After we have a portal venous cases in the X-ray. For that, there is a X-ray. After that, there is no portal venous cases in there.
Oh, which other thing is significance in your this X-ray? Yes.
Yes, ma'am. There is a gaseous distension of the bowels is there, and lungs are well recruited, and livers are okay, no portal venous cases, and RT position was good. Stomach bubble, gaseous distension of the stomach was there, and we have inserted peak line. Peak line was visible.
No, madam wants to ask the stage of NEC, Bell staging, modified Bell staging, that we want to do a surgery or only medical treatment. You have done staging or not? Bell's modified staging. Stage 1 is probable, proven, and
Stage 1 is
suspected.
suspected. Stage 1 is probable for stage 1 and definite for stage 2 and advanced in a stage 3.
Yeah, so staging is important, and like what are the indication for surgery? And what hematological parameter indicates the severity of NEC? What two parameters, hematological parameters, indicate severity of NEC?
Sorry, hematological parameters are severe thrombocytopenia.
Very good. If more severe is the thrombocytopenia, and second is
metabolic acidosis.
Very good, metabolic acidosis. So you have done the ABG or not? You have gone for a platelet count or not? And on serial X-ray, you will get fixed bowel loops or pneumoperitoneum. So what are the absolute indication for surgery?
Absolute indication for surgery is the two. One is the pneumoperitoneum, free air under the diaphragm, and next is a fixed peritonitis.
Peritonitis is the absolute indication, and relative indications are if the baby is not improving on medical treatment, and there is fixed bowel loop on serial X-ray.
Yes.
Abdominal wall erythema.
Yeah, correct, ma'am. Yes.
Day 11 of the X-ray of day 11, which is the gaseous bowel was there.
In the previous X-ray, can you show me the pneumatosis intestinalis?
Yes, ma'am. There is a. This is a pneumatosis intestinalis. This is.
So that is a significant finding.
This is a significant findings of stage 2A.
Yes.
Subserosal layer. Subserosal layer.
Stage 2A.
Okay.
In this day 11 of X-ray, there is a gaseous distension is there. There is no Numerous intestine in this X-ray, and no air under the diaphragm was there. In day 12 of life, the baby was still NBM, RT aspirate 2 ml browns. Baby was on DOPF. CBC was there. It is no thrombocytopenia for that. One PCV planned. One PCV was planned for the anemia. VBG was suggestive of a pH of 7.17 and base deficit was -9. There is on this day, this X-ray was there. In this X-ray, there is no air under diaphragm, no visible any numerosis intestinal leach was there.
But in your serial X-ray, are you able to see any fixed dilated loop? So will you be able? Are you able
No,
to trace it, or there was no fixed dilated loop?
No, ma'am, we are not able.
There wasn't any. Okay.
On day 13 of life, the baby is still NBM on day 5 on DOPEP. CRP was 2, sodium was 134, potassium was 4.3, create was 0.6, and blood culture was no growth in final culture. Then day 14 of life on DOPEP, baby was still in NBM. RT aspirate was 3 ml brownish, INR of 1.5, FPTT was 62. CBC was done, which is 11.4 of HB, 34 of PCV, 21,000 counts, and 1 lakh of platelet. Abdominal distension was there. The VBG was done, which is 7.25 pH, 47 of PCO2, 40 of PO2. Bicarb was 20.7, and base deficit was -7. X-ray abdomen was done for that, which is
the child was NBM since last around 7 days.
Yes, ma'am.
Right? From day 7 onward, the child was NBM.
Yes, ma'am.
And the RT aspirate that came on day 14. Up till that, there is no RT aspirate.
Ma'am, RT aspirate was there from day 12.
Day 12.
And day 12, NBM, and day 9, ma'am. Day 9, from day 9.
Okay. So brown RT aspirate was coming since day 9, and it
Yes,
has not improved up to day 14. It was continuous.
Yes, ma'am. Which was we have investigated for that. This is CBC, which is a platelet count was 1 lakh, INR was 1.5, and FPTT was 62. And the abdominal distension was there. For we have go for X-ray. There is a X-ray abdomen, which is clear air under the diaphragm, and multiple gaseous loop of intestine was seen. X-ray suggestive of pneumoperitoneum. We have set a continuous RT aspirate. Metrogyl injection was added and intubated. Pediatric surgeon reference was done, which was advised exploratory laparotomy or a peritoneal catheter, drainage catheter, or a relative was counseling about the prognosis and state of disease, but they would not want to continue treatment, and the withdrawal was taken. There is a ABG chart of day 1 to day 13. For we have seen there is a pH of 7.3 to last one was 7.2, and base deficit of was on admission -6.7. In between day 7 or day 9 there is a 13 or -13 -12. On day 13 there is a -7 was base deficit. Investigation was done. This is chart. There is a PCV was given on day 7 on 9.1 of HB, and initially we have planned FFP 110 of FPTT, then 2.1 was INR, then we have started feeding one normal of INR 1.3 and 70 FPTT. There is RT spirit on day 9. And H on day 10, which was INR was 1.5 and APTT was 60. Day 11, which is a 10.5 HB, 29 of PCV. We have planned a PCV for that. And day 14 is the last day, which is a platelet was 1 lakh and INR was 1.5 and 62, which is APTT.
Summary. As per your investigation chart summary, the baby started deteriorating mainly from day 4.
Yes, ma'am.
So what that deterioration has been diagnosed as, or what you have given it as contributing factor?
Ma'am,
like your HB is also started decreasing from day 4. Your ABG are also bad from day 4.
Yes, ma'am. One is factor
you attributed it to which diagnosis?
Ma'am, sepsis is one of the diagnoses, which is the
you didn't change antibiotic to day 4. It was changed on day 7.
Day 7. We have changed day 7.
This is hospital-acquired infection. Hospital-acquired infection. Hospital-acquired infection. CRP initially was negative.
CRP was negative throughout the stay, but we have ANC count was low in day 7, which was 960.
ANC count was low very late. It wasn't low initially.
No, not.
It was also a sign of your sepsis only, and that was hospital acquired.
Yes, yes.
Yes. So at day 4, you should attribute all the these things of investigations, deterioration, and the clinical deterioration to the late onset sepsis, hospital acquired infection. Because your X-rays were very well perfused lungs, well ventilated lungs throughout.
Yes, yes.
Okay, go to the last slide.
Summary, twins 2 or baby of 26-year primary gravida mother, which was conceived by IVF pregnancy, delivered at 26 plus 6 weeks of gestational by a cesarean section in view of severe PIH, and had a twin pregnancy. DCDA twins was delivered, which is twin 2 was aggregate for gestational age, extremely low birth weight, which is 780 grams. Male baby was delivered. Respiratory distress syndrome. For that, we have given 1 dose of surfactant. For coagulopathy, we have given 5 FFP and 1 cryoprecipitate. For anemia, we have given 2 units of PCV and NEC grade 3B, which was seen in pneumoperitoneum.
I just want to ask you, what rectification will you like to do to survive this baby? What rectification you could have done to survive this baby starting from the labor room? What are the latest guidelines?
Yes, sir. In a labor room, we can start on a TP's resuscitator. We could transfer on TP's resuscitation, and bubble CPAP trial can be given, and ensure less invasive surfactant therapy can be done, and we should go for early upgradation of antibiotic. And
what actually minimal handling protocol, do you know that? You must have done so many times ABG, and so many times you must have done X-rays. So like if you handle, this baby had IVH, so you know how to prevent IVH. This is minimal handling and swaddling, nesting, and all sort of not to disturb baby, and sleep-wake cycle you have to follow. So like you have to do minimal handling and minimal pushes and minimal letdown. So many times you have taken blood for PT-INR. It requires a large amount of blood, and you should know how much amount of blood you have let down. It should be charted on the nursing staff table that this much amount of blood has already been taken. So as you know, in NEC, hypotension and ischemia is one of the factor. It is multifactorial disease and ischemia is one of the factor for NEC. So baby must have gone in hypotension and ischemic damage to the intestine. Okay, and the second most is babies of NEC who develop NEC are most of the times already fed. So this baby was fed milk. The other way around is that do not deny any baby from giving colostrum. You have to instill colostrum in the pharynx of the baby because it is rich in antibodies, amino acids, complements, lactoferrin. So you should have given a mother's milk colostrum to the baby at the time after stabilizing the baby in the nursery. It prevents NEC also. Madam, you want to add something?
Yes. Do you know what is colostrum painting?
Sorry, colostrum.
Colostrum
Colostrum. Yes, ma'am. Colostrum painting can be done in baby's mouth and oral cavity.
So how it is done?
By a little finger can be used in little finger with little finger.
Which is collected, you know, how that colostrum is collected?
No.
Okay, tell me any other surgical intervention you could have done for this child?
Correct.
Explain, except this exploratory thing.
Primary peritoneal drainage can be done for the baby, and conservatively it could be managed.
Yeah, it has got good results also. Only if the baby then survives, second look operation is required. So if baby is not possible to be transferred to the OT, you can do PPD. Okay, and you can relieve the tension and fluid from the belly, and so that respiratory embarrassment may not take place. So you have done PPD or not?
No, sir. Relative counseling about both the thing, exploratory laparotomy and PPD, but the relative don't want to continue the treatment and then withdrawal was taken.
You have bubble CPAP in your nursery?
Yes, sir. We will CPAP with that.
You should not use ventilator too much. Nowadays, only CPAP, nothing. HHFNC and CPAP. All non-invasive. Everything is non-invasive now. Lisa, MISA, all non-invasive techniques.
Yes.
Okay, so Sanjay, we are about to time for Prashant.
Yeah, perfectly. Dot on time.
And actually, it takes a great courage also to present on the platform. So I congratulate for you for this. And whatever is discussed, that is good for you and even for the preparation of other case or examination.
Yes,
so good attempt.
Thank you.
I still congratulate you. That's good. But we haven't discussed any theory part, but still practical parts we have discussed. And great going. Great. Good.
Thank you, sir.
Please stop the screen. Share. So thank you so much to all the both the faculties. Sir, actually Sanjay has learned a lot, and I'm sure the students who are watching must have learned a lot, because this was totally a practical training. And on behalf of NNF Gujarat, I thank our both the experts as well as the presenter Sanjay. So as Dr. Nehal ma'am said, it is actually courageous things to present online, because while you're presenting in an exam, only you and two examiners are there. Over here, plenty of, I will say 100 of people are watching you, and they are commenting that this is right or wrong. So thank you so much to our today's presenter, Sanjay Chavda, for presenting a case in Neonatal Pathshala, the Presidential Action Plan 2022 of NNF Gujarat State Chapter. And we also thank our expert, Dr. Vivek Arora sir and Dr. Nehal Patel ma'am, for taking a case wonderfully. So thank you so much. Those students who are still watching us, please join us next time on next Wednesday, same time, 3:30 p.m. by joining on this.
Comments. Yeah. There is 2 comments.
There are 2 comments which we'll take. Yeah. So next week will be at 3:30 p.m. Neonatal Pathshala. ground rounds, that will be a practicing pediatrician's point of view will be useful. So that will be a one thing. And second is, sir is in Udaipur. So we are glad to say that, sir, we are hosting West Zone Neocon in Udaipur on 26, 27 and 28 August. So we request all the participants who are there to register for the West Zone Neocon. There are two questions in a chat box. Sanjay, if you can answer, otherwise then we will ask to our experts. What is the commonest site of involvement in NEC? That is asked in chat box. Sanjay?
Commonest site for the NEC, which is a distal ileum and proximal large colon.
Correct.
Yeah. And second thing, the participant want to ask that the child was having NEC and huge stomach gas collection. Still, you kept the child on DOPEP. Why?
So we have kept a DOPEP for that. We have a 2 extubation failure. There is a 2 times extubation failure. So we have planned to shift the first DOPEP. Then we can plan for bubble CPAP and SFNC.
No,
So
other thing is
why
that
not
if the
ventilate?
baby is on duopap, what you should have, I think you must have done, you could have placed the RT and keep it open. That would have decompressed the intestine.
Yes, sir. We have done that.
Okay, good.
So thank you so much. And with this, we come to the end of today's Neonatal Pathshala. See you next week, same time, same link. See you soon. Yeah, thank you.
Bye. Thank you all.
Yes, sir. Thank you.